All right. Again, thank you everyone for joining the Norton Infectious Disease Institute Grand Rounds, What Keeps You Up at Night. And our first presenter today is Dr. Melissa Horton.
Good afternoon, everyone. I wanted to start by just letting you know that this presentation was funded by the Kentucky Department for Public Health. We had no commercial support, and none of us have anything to disclose. So the first thing that I want to talk about is the New World screwworm. We've heard about this on the news, and it just grosses me out. So that's the topic that I chose. And you can see this little screwworm here on the right. So the New World screwworm is the larva of a fly in the Calliphoridae family. I'm sure I'm spelling that or I'm pronouncing that incorrectly. And the larvae are obligate parasites that infest and consume the living flesh of warm-blooded hosts. Now, we often think about things like maggots that we sometimes see in a hospital. The thing to know is that maggots, while they are disgusting, typically are eating only dead flesh, and this is the opposite for the screwworm. It is going to eat healthy flesh. Now, the things to know that are important is that the female flies only mate one time in their lives, and once they lay the eggs, they hatch within 24 hours, and those maggots or larvae will remain in the body for up to a week. The life cycle, these eggs are laid in a mammal. The larvae hatch and then they start burrowing into the skin, into soft tissues, feeding on that, living tissue. After about a week, they will be big enough that they will fall from the host and land in the dirt, where they will eventually become adult flies and the cycle will restart. Now, the adult female flies are attracted to odors produced by wounds and mucous membranes of warm-blooded animals. So they can be attracted to wounds that are as small as a tick bite. They are attracted to the umbilicus, the mouth, nose, ears, eyes, and genitalia of humans. And again, they're very destructive and they really tear those tissues. So you'll end up, you may start with a very small wound, but this wound will increase in size and depth. It will become very painful, swollen, and you can typically see the larva in the wound. Now, of course, the risk factors are going to be what we see most of the time. People that are immunocompromised, the very young or very old, people who have some sort of limited mobility where they can't protect themselves, people who sleep outside, have poor oral hygiene, and of course, those that work or interact with animals in an area where this fly lives. The next two slides have some very disgusting images, so look away if you would like. These show animal infestations. The one on the left is a deer, and the one on the right is the neck and upper back of a dog. And as disgusting as that is, I included it because you can very easily see all of the larvae in that wound. And then human infestation. So we have an ocular infestation on the left patient. I think this is an ear. I can't quite tell, of an elderly patient that has a history of lymphoma. And on the right, an elderly man. This looks like it's on an arm or leg, and it looks like it's potentially starting to heal. Okay, disgusting pictures are over, mostly. There's one case we have of an American woman, a 26-year-old that traveled to the Dominican Republic. She did fall asleep on the beach, and the next day had some itching or something in her ear, and she got a fly out. The next day, she developed acute ear pain and discharge. She sought medical care, and larvae were visible in the ear canal. So she ended up going to the OR with ENT. They found that the larval infiltration had extended to the temporal bone, and the TM had been perforated. So you can see how much damage was caused just in this short period of time. So what have we done so far to control this? There's been an international collaboration to control this by breeding and releasing sterile male flies. Remember, the females only breed or only have breed one time. So if they breed with a sterile male, they won't get pregnant. They won't be releasing any eggs. And this had been really working pretty well until recently. Right now, the United States has stopped animal imports through the southern border of the US. And the US and Mexico are working to produce more facilities to produce even more of the flies. You can see towards the bottom of the screen, that bottleneck there was just a much smaller area that needed to have the sterile flies. And as we go further up towards the United States, there's just a huge number, or a huge landmass. We'll need a lot more of those sterile flies. So for prevention for humans, what would be to keep any wounds covered, wear long sleeves and pants, wear some sort of DEET containing pest deterrent, avoid sleeping outside, and then using nets or screens around the sleeping area if you're in an area where these flies live. And then, of course, not sitting on the ground where these flies live either. In animals, you would want to increase the frequency of checking the animals, make sure that you're using fly repellent, treat any wounds promptly and cover them if possible, and then delay any wound-causing tasks to a time when there are less flies, so in the winter. And those things can be things like castration, which would cause a wound, tagging the ear, or removing horns. Now, for the diagnosis and treatment, I've shown you the picture. It seems like it's pretty easy to diagnose. You would need to remove every maggot or every larva, every one of them, and there can be up to 300. You need to kill these by placing them in 70% alcohol, but you need to keep 10 of these larvae to send to the CDC for testing. And that is true for human infestations and animal infestations. This may require some extensive debridement of the wound, so would need frequent wound checks to make sure that all the larvae were removed and that the wound is healing as it should. Obviously, someone's, human or animal, with the size of these wounds will need some sort of pain management. And there may be some secondary bacterial infection that required antibiotic. In humans, we have used ivermectin as a one-time treatment, but it has not been FDA approved for these cases in humans. And then animals do have several topical options to apply to the wound. And the second, a little bit less scary, but also a little more scary, I don't know, is the alpha-gal syndrome, or the red meat allergy. So what is it? It's a molecule that's naturally produced in most mammals, but it's not produced in humans. It can be picked up by the Lone Star tick when it bites an animal, and then transmitted to humans with a tick bite through their saliva. And this can trigger an immune or an allergic reaction. So the immune system recognizes this as something foreign, and you develop an allergic reaction. Most of the time, the symptoms come after the person eats red meat or comes in contact with products that were made from animals, like gelatin, lard, beef broth or gravy, sometimes milk and milk products, and then some medications. So how did we discover this? So in 2004, an antibody was approved for treating some types of cancers. And shortly thereafter, there were reports of some of these patients using this medication, developing allergic reactions and some deaths. So at that point, they began to investigate. They developed the test for alpha-gal. And since 2004, these cases have increased every year. And if you look at the map on the right, the dark blue are the highest number of cases. So you can see that's the American Southeast, which is coincidentally where you're going to see most of the Lone Star ticks. I thought of this because of this news report that was very recent. It was a healthy man who had an episode of severe belly pain, vomiting, and diarrhea. He'd been camping. He had a steak about 4 hours before. This was, apparently very terrible, but it resolved after 2 hours, and by the next day, he was kind of back to himself. About 2 weeks later, visiting a friend, he had a hamburger, and then kind of went about his normal life. About 4 hours later, those GI symptoms returned, and very quickly he lost consciousness. And despite CPR being initiated, he did not survive. When they tried to figure out what in the world caused this healthy man to die so suddenly, initially everything was very unrevealing. But they did eventually test for the IgE to beef, and for this man, it was positive. And there were some other lab tests that indicated that his death was due to a fatal anaphylaxis. So this was a man who had one episode of GI discomfort and then 2 weeks later died. And I just think about all the times that I have a bellyache or don't feel well, and you may never know that this is because of an allergy. So symptoms will vary from person to person. So they can be very mild or they can be life-threatening. They typically occur 2 to 6 hours after exposure. And so it's going to be the typical allergic reaction symptoms. You could have a rash, nausea, vomiting, diarrhea, dizziness, shortness of breath, of course, anaphylaxis. And the abdominal pain in these cases usually is really severe. Now, because the symptoms might not appear for months after you've been bitten by a tick, and then there's a delay in any symptoms after exposure, it makes the diagnosis really challenging. So if this is suspected, can make the diagnosis with a good history and an IgE blood test that's very specific for alpha-gal. There may be some allergy testing of the skin. One of the things that you have to have for this diagnosis is there has to be some response to the diet. So either you eat meat and you have symptoms, or you stop eating meat and the symptoms resolve. There are some patients that have only GI symptoms, so they may have a diagnosis of like something like IBS for a long time before an allergy is considered. And the interesting thing about alpha-gal is it doesn't follow the predictable pattern of IgE-mediated allergies. So if we do a blood test, there may be people who have very high IgE for alpha-gal who have absolutely no symptoms and they can eat meat with no problem. And you can have others who have a very, very low IgE who have anaphylaxis. So it's really hard to determine how bad symptoms might be based just on this test. And there's also people, who do have alpha-gal who don't have any symptoms. So it's a mystery trying to figure out why some people develop this allergy and some don't. So the management really is going to be avoid products that contain alpha-gal. That's going to be beef, pork, venison, lamb. You want to prevent any future tick bites. Some people do have an allergy to milk and milk products, but not everyone. So that may be something that needs to be trial avoidance to see if that helps. And then for patients, they may need to carry an EpiPen because just because you have a mild reaction the first time may not be true the second time. Some of the medications that we use do contain alpha-gals, like some of the vaccines, some of the medicines like heparin, Synthroid. Some of the medications may have lactose, and most pancreatic enzymes do contain alpha-gal. And so this becomes really challenging because medications don't have to list mammal ingredients, and allergen labeling is not required for meat in the US. So you might see those little warnings like that this was made in a factory that may contain milk or soy, but there is no requirement for meat in the US. A lot of healthcare providers have a lack of knowledge about this. And then of course there is animal products in so many things. So it could be in foods, lipsticks, lotions, even clothing like cashmere and leather. Soaps, deodorants, cosmetics, and some pets can carry alpha-gal in their dander. So avoiding red meat and red meat products can be really challenging. I'm going to hand over now to Kirsten.
All right, everyone. I'm Kirsten Trudeau. Things that keep me up at night include bats, rats, and some, if not most, birds. First, I'm going to talk about hantavirus. So this unsuspecting little rat that some might call cute could be really dangerous. So hantavirus is a family of viruses, the Hantaviridae. There are about 50 different species of hantavirus. It is spread by rodents. Typically, it's not a human transmission. It's usually spread by urine, feces, and saliva. Now, I say typically because there is one strain known as the Andes virus that has been known to have human-to-human cases, but that has not been reported in the U.S. Those have been more isolated to like Argentina, Chile, a few more countries, outside of the U.S. And then typically this is caused by breathing in the virus. And so the types and clinical manifestations of hantavirus are the non-hantavirus pulmonary syndrome or the non-HPS. This is the one you would want if you had to choose hantavirus. Hantavirus pulmonary syndrome, or HPS. Now, this is endemic to the Americas. And then hemorrhagic fever with renal syndrome, or HFRS. It is endemic to Europe and Asia. And then there's the Sol virus, which is more global. So like I said, it's spread by bodily fluids, urine, feces, saliva. You can breathe it in from contaminated air, touching contaminated items, bites and scratches from the infected animal, and then contaminated food. Nesting material also poses a huge risk. If you look at the cases of hantavirus in the US, you can see that on this map that most of the cases, the greater number of cases are more in the western United States, but there are still some cases in the middle United States and eastern. Some of the symptoms, most of them start out as nonspecific viral symptoms. And then if it advances to the HPS or HFRS, either of those strains, for HPS, you would end up with hypotension, pulmonary edema, hypoxia, myocardial depression, and arrhythmias. If the HFRS is the manifestation, then it would be an intense headache, back pain, abdominal pain, blurred vision, nausea, vomiting, nausea, fever, and chills, and then later symptoms of shock. So for the HPS, you typically start with those flu-like symptoms, and then in about 2 to 5 days, you have rapid non-cardiogenic pulmonary edema and hypotension. The HFRS, thus incubation is a little bit longer, about 2 to 6 weeks before you develop those symptoms. And then if you have the non-HPS version, those symptoms are more, that manifestation is more mild and can be asymptomatic. So testing for this would be the ELISA for IgM antibodies. You could look at IgG, which would be positive with increasing titers, immunohistochemistry, and PCR. There is no specific treatment for hantavirus, which makes that even more scary. And if that supportive care is not managed appropriately, most deaths from HPS will occur within 24 to 48 hours of cardiopulmonary involvement. Prevention for hantavirus is really avoiding contact with those animals and avoiding contact when you have to clean up after the animals. So you want to get a general household disinfectant or a bleach solution if you have to clean up any rodent droppings. And you actually want to make sure you put on gloves and then spray that disinfectant on the nesting material, on the rodent's feces, anything left behind from the rodent. And this is the same for if you trap a rodent. So if you have a mouse trap or, some type of rat trap, you want to spray the rodent itself. Let this disinfectant soak for 5 minutes. Again, make sure you're wearing gloves. Clean up the rodent, clean up the nesting material, and then make sure to dispose of them properly. Wash your hands. Biggest thing is don't vacuum it up. Don't use a broom to sweep it up. Don't use a leaf blower, because any of these things can stir up that virus and cause inhalation of those aerosols. Next on my list of what keeps me up is histoplasmosis. Again, some people might think this bat looks really cute. I personally am very afraid of it. So histoplasmosis is a fungal infection. It's caused by Histoplasma capsulatum or Histoplasma Capsulatum bar duboisi. The histoplasma actually lives in the soil, but the thing about birds and bats is that the histoplasma really thrives in areas where there's a large quantity of bat and bird droppings. Now, one thing to note is that birds are really rarely ever infected with histoplasma themselves, but bats can actually be infected with this. So how this is transmitted is breathing in these spores. And so once the spores enter the lungs, the person's body temperature really allows those spores to transform into a yeast, and then that yeast can travel through your lymph system and spread to other parts of the body. So it can manifest in the lungs as pneumonia, in the brain as meningitis, or other parts of the body. So you can see for histoplasmosis that there are areas that, where it's likely to be hyperendemic. And so you've got, areas here in the US, South America, Southern Africa, and Asia. There are areas where it's less likely to occur, and then you've got areas with locally acquired cases as well. In the US, areas where it's more likely to live is definitely in the more mid east of the United States. And so it's very, very much prevalent in the Mississippi and Ohio Valley. You can see here that this is where outbreaks have occurred of histoplasmosis. And again, same area. Again, the Ohio Mississippi Valley is a place where histoplasmus thrives well in the soil. This is just an example of how people can get histoplasmosis. So really, things that you would consider to be a risk would be disturbance of large accumulations of the bird or bat droppings, any type of soil disruption. So if you work in construction, like digging, excavating, any type of handling of trees, landscaping, disrupting that plant matter, agriculture, farmers, any type of demolition, construction work, anyone that works in or explores caves. If people have risks that involve an occupation that deals with bats and birds specifically or other animals, and about a third of the outbreaks in the U.S. are work-related, and those top professions are bridge workers, construction workers, farmers, landscapers, and microbiology lab workers. The symptoms of this are generally mild, 3 to 17 days after breathing in the spores. And the good news is this typically does self-resolve in about a month. The symptoms are pneumonia symptoms, fever, cough, extreme tiredness, chills, headache, chest pain. But if it does progress to those severe cases, then you're looking at a long-term lung infection, meningitis, presumed ocular histoplasmosis syndrome, which can cause blindness. Really scary stuff. So the likelihood, if you live in the Ohio Mississippi Valley, that you've had histoplasmosis and self-recovered is pretty good, but there is the risk that you could have those severe cases, which is concerning and keeps me up at night. Risk factors would be immunosuppression, infants, and anyone greater than 55 years old. Diagnosis would be through urine or serum antigen detection is most commonly used. Again, treatment, typically this is mild to moderate and will resolve without treatment, but more severe long-term cases really have to be treated with approved antifungals. And that takes a pretty long time. So I am going to hand it over for the last What Keeps You Up at Night, which is Rabies by Dr. Julia Frith.
All right, so let's go ahead and get started with rabies. Well, there are many things that keep me up at night. Rabies, at least of late, has made it to the top of my list. So rabies is actually a serious public health problem. And it impacts over 150 countries and territories, mainly located in Asia and Africa, as you can see there on that map. 40% of the cases are in children, and dog bites and scratches cause about 99% of human rabies cases. Once the virus infects the CNS and clinical symptoms appear, it is 100% fatal. When you look at the cost of rabies from a global perspective, the cost can be about $8.6 billion per year. And there's about 59,000 deaths per year globally. And there could actually be more related to underreporting. And over 29 million people receive the human rabies vaccine annually. So let's talk about a case that has made headlines lately. And I took this timeline here from the MMR that was done by Ernest et al. Just in December. So a quick rundown. So there was an individual in October of 2024 who was approached by a skunk while holding a cat. During this encounter, the skunk approached the individual and scratched their leg, and the scratch bled. but they did not feel like they had actually been bitten. About 5 weeks later, the individual developed symptoms, including difficulty with swallowing, walking, and hallucinations. And then 2 days later, they were found unresponsive in their home. And it was secondary to what was thought to be a cardiac arrest. They were taken to the hospital, and unfortunately, they did not survive. The individual did donate their organs, including their left kidney, their heart, their lung, and both corneas. Three individuals received those corneal grafts, and one individual received the kidney. And the heart and lungs were not transplanted, but were used for training purposes. About 5 weeks post kidney transplant, the recipient began to develop symptoms consistent with rabies. This individual also received medical care, and unfortunately, they did not survive their hospital stay. Specimens collected from the recipient were positive for the silver-haired bat rabies variant from that kidney and some other specimens that they collected. Upon investigation, the stored serum from the donor was tested for rabies, but was found to be negative. However, they were able to do a biopsy of the right kidney, and it was positive for rabies RNA. There wasn't enough tissue for testing of the left kidney, and so it was not tested. As a precaution, the corneal transplant recipients underwent graft removal. They received PEP, and they have all survived to date. Multiple individuals were found to have been potentially exposed through a risk assessment that was done through the health department, and those individuals also received PEP. From 1978 to 2013, though, there have only been 4 transplant-related rabies cases in the United States, so this is clearly very rare, but this case has obviously made headlines for sure. So let's talk about the rabies virus really quick. So the RABV is typically responsible for most human cases. Like I said, dog bites are the primary source of rabies, particularly in Europe, Asia, and Africa, not so much in the United States or the Americas. In the Americas, bats are the primary source. And death from bites from other wild animals such as fox, raccoons, skunks is rare, though they can be infected by rabies, as the case prior highlights. So they can be infected and then bite someone and cause them to be infected. It's contracted through the saliva from a bite of an infected animal, and it also could be through other routes, but human-to-human transmission, while in theory is possible, has never been documented. The severity of the bite and the type of rabies virus, they could potentially matter. Infection with a dog rabies virus may be most likely with an individual that has had a deep wound, like a bite, but the infection with the bat rabies virus can occur from just a scratch to the skin. And so, like many viral infections, there are clinical stages that are associated with this. So the incubation period is about 2 to 3 months. It may vary from 1 week to a year, depending upon the viral load of the bite or the scratch. The symptoms include those typical benign symptoms: fever, pain, and irritation at the wound site. This can be like tingling or prickling, and then ultimately it moves to the CNS involvement. So there's 2 forms. There's the encephalitic and the paralytic. The encephalitic is those individuals that develop, or those animals that develop that hypersalivation, agitation, hydrophobia, so a fear of water. And interestingly, in developing countries, this may be offered to individuals that are suspected to see if to develop a diagnosis. Death occurs after a few days due typically to cardiopulmonary arrest. In the paralytic side, it's about 20% of the cases and can be misdiagnosed for something else. These individuals develop muscle weakness that is gradually starting at the wound site, have a coma, and then ultimately death as well. So really quickly, we know that how do we prevent rabies? We know that vaccination programs work. Dogs getting vaccinated is the most effective. It stops rabies at the source. It's not recommended to do culling. According to the World Health Organization, that is not an effective method for rabies prevention. People, if you have exposure, there are pre and post-exposure prophylaxis protocols. So prevention of those individuals that have high-risk occupations. Maybe you travel to a location or you plan to travel to a location that has a high risk for exposure to rabies, or living in a remote area where rabies is endemic. And have limited access to those rabies biologicals. So thinking about somebody who might work in a lab handling the live virus for research or investigation, or a wildlife ranger or something of this sort. And so those individuals would be candidates for pre-exposure prophylaxis. To be clear, pre-exposure prophylaxis does not replace the need for post-exposure prophylaxis should an event occur. So in the event of post-exposure, there would need to be for wound washing. You would receive that rabies vaccine, and then if indicated, individuals would receive that rabies immunoglobulin or the monoclonal antibodies into the wound as indicated. And these have been shown to be very effective if provided to an individual before symptoms occur. And that is all we have. So I hope that everyone enjoyed what keeps you up at night. It was not easy picking all of the topics, because there are a lot of things that could potentially keep us all up at night. But that is what we have. If you could also, if there's any topics that you would like to have in the 2026 grand rounds, please put them in the chat. And if anybody has any questions. All right. Thank you all very much. Have a great rest of your week.
Okay. Huh?